Okay, well, thank you for joining our discussion today on faith leaders and COVID-19. I'm Doug Fountain, Executive Director of CCIH. If you're new to Christian Connections for International Health, we are an international network of approximately 115 Christian organizations and 15 affiliated partners, as well as a few hundred individual members working in over 90 countries around the world. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, fellowship, and advocacy. Today, we will hear from a couple of our speakers and then have a break for questions. Then we'll hear more speakers and follow that with questions to everybody. Please use the Q&A box on Zoom to type in your questions, and we'll answer as many as we can. Please do not use the chat for questions for the speakers. Use that Q&A box at the bottom. This webinar is being recorded and will be posted on the CCIH YouTube channel and posted on the CCIH website at ccih.org under the Resources and the Immunizations tab. You will get an email with a link to the recording when it's posted. Now, a little more about our topic today. In our global response to COVID, many people herald vaccines as a way to protect life and promote health in its fullest sense, which is very much part of the mission of the church. There are, however, voices that object or raise concerns about vaccines, and sometimes those are even found within the church. Some vaccination campaigns involve faith leaders, yet there is enormous potential for this powerful resource to help people overcome fears, mistrust, and misinformation. CCIH collaborates with many of our members on this important work, and today we're delighted to co-sponsor this session with World Vision. Let's hear some welcoming remarks from Mike Odera with World Vision, who will in turn introduce our moderator for today. I'll come back for our closing. Thank you. Mike, over to you.
Thank you very much, Doug, and good morning, good afternoon, and we're looking forward to hearing today's presentation. As a faith-based organization, continuously seeking ways to share the evidence and impact of our work, especially regarding our strong collaboration with faith leaders and communities all over the world, we as World Vision are very thrilled to co-host today's conversation. Through World Vision's partnership response to this devastating impact of COVID over the last year and a half, we have reached over 59 million people to date. On the ground, World Vision is actively investing and building local capacity for vaccine acceptance, and also encouraging voluntary uptake by engaging communities, faith leaders, civil society organizations, community health and development workers in both stable and fragile settings to spread accurate vaccine information, encourage vaccine acceptance, and move people to voluntarily seek to be vaccinated. We're expanding our COVID-19 programming and global fund work, from which we have received funding to address behavior change, support cold chain maintenance, provide personal protective gear equipment, and produce locally made face masks. To date, World Vision has reached over 139,000 faith leaders and 184,000 community health workers in close to 45 countries to disseminate a range of integrated public health messages, including messages very specific to COVID-19. At our core, World Vision is a child-focused organization. We're focused on ensuring that the COVID-19 vaccine does not disrupt other childhood vaccinations like polio or pneumonia. We advocate and collaborate at national and subnational levels to strengthen our governance systems, policies, and structures to reach the most vulnerable in the most difficult areas. We're also calling this the last mile. So I'll be joining you today in actively listening and looking for nuggets of information that will advance the efforts of partners, local organizations, faith community, and our donors. So let's make this an interactive discussion. Feel free to post questions in the chat box as they come. With that said, I'll turn it over to our moderator for the day, Susan Ochri. Susan is our Senior Director for Health here with World Vision and the US. She served as Project Director for the World Vision's birth spacing programs, and also was a Technical Director for Cardinal. Welcome again, and over to you, Susan.
Thank you, Mike, for that introduction. And as we all gathered here, we know the influence of faith leaders and other community leaders is very powerful. So really excited to be talking about this resource and how we engage with faith leaders and our community leaders to end the global COVID-19 pandemic. So welcome everybody, and let's dive into today's presentations. It is an honor to introduce our first speaker in the person of Ellyn Ogden, who works with Usaid in the Global Health Bureau. Ellyn Ogden has been the Worldwide Polio Eradication Coordinator and Technical Director of Usaid and a Senior Director, Senior Technical Advisor for Health and Child Survival since 1997. She is responsible for Usaid's polio eradication effort and supports disease surveillance, communications, and civil society engagement in over 25 countries, and is currently the Emergency Operations Center leader for Usaid's COVID-19 Vaccine Access and Delivery Unit. Ellyn will share with us about Usaid's priorities and strategic engagement with faith leaders. Pleasure to have you, Ellyn, and over to you. Thank you.
Thank you so much, Susan, and it's a real pleasure to be here. Over my 25 years in polio eradication, we've had tremendous opportunities to work with faith-based leaders and organizations in dozens of countries around the world. Next slide, please. And we've learned a lot. This picture is from one of my very first meetings in Ethiopia, where there was a launch of a polio program, and they brought together faith leaders from all over Ethiopia. And that really highlighted the importance of the need to work at the international level, the national level, and across regional organizations such as the Islamic Advisory Group for Polio Eradication, which brings together scholars, theologians, and philosophers to really identify where faith plays a role in immunization and helps to spread the word systematically across the various sections and subsets of various religions. We involve faith leaders most effectively when they're involved from the beginning in planning. How are they going to participate in the immunization activities? It should be part of our micro planning at the local level. It goes beyond informing about the dates of the campaign or about the safety of the vaccine. It really comes down to being a vocal advocate. And it also comes down to engagement. How do we assist in the activities themselves? Some of the ways we've worked with faith leaders at the local level include tracking newborns and high-risk populations, making sure the teams go to those households first, or making sure those people for COVID are brought to the facilities first. We can help address barriers when there are few female vaccinators. This is particularly true in conservative Muslim countries. And we have worked with faith leaders on improving poor team performance, because when the teams don't perform, this information is conveyed back not only to the various programs, immunization programs, but to local political leaders. And when it's also reported to the religious leaders, there's an expectation of high performance. And we have also worked with faith leaders and religious, whether it's churches or mosques or shrines, to identify potential cases of polio or COVID or other diseases. Religious factors are the third most frequently cited reason for not getting vaccinated. And so the voice of the religious community is absolutely critical in making sure, no matter which vaccine is being used, that there's confidence, that they know there's a social norm, that they're part of serving their communities and protecting not only themselves, but their loved ones. Next slide, please. We have learned the importance of listening and dialoguing with religious leaders. This is me in a meeting that was very impromptu in Aligarh, India, and I had been monitoring the polio campaigns. And they were doing a very good job. And I had been walking with the imam, and he was tracking newborns, and they were going to every house, and it was an excellent job. And he said, no, my leadership wants to meet with you. And I said, but why? You're doing great. And he says, they really want to meet with you. And somebody from UNICEF whispered in my ear, I think they really want to meet with you. So I said, sure, let's meet. And right there in the street, chairs came, munchies came, and the man that is to the right of me with the white beard says to me, he says, we have a very important question for you. And I could not imagine what that could be because so many technical advisors and people had been there before me. And he said, what is it about our faith, about our being Muslim, that makes us more susceptible to getting this disease of polio in this case? And I said, there is nothing about being Muslim. And I would have said the same for any religious gathering. There is nothing unique about your religion. It's just you have poor services. You don't have enough immunization activities. You have been neglected by the general approach. And you could hear a collective sigh of relief that there was nothing genetic. There was nothing in them themselves that was a predisposition to getting sick. It's really about access to services. And once we had that, we began a dialogue with the political leadership sitting to my left about how to bring immunization services into these underserved communities. And so bridging that gap between religion and religious-based organizations and local influencers and the political side, as well as WHO, UNICEF, and other implementing partners, we were able to make great progress in building confidence and in moving forward. Next slide, please. We have also learned a lot about systematic accountability. We were working ad hoc with lots of different religious groups. And in Nigeria, it really became apparent that we needed to have a much more systematic approach. And so we organized a religious leaders forum for polio eradication that was organized out of the office of the Sultan. It worked directly with the National Primary Healthcare Development Agency. Each person within the organization had a role, a responsibility. There were training materials, consistent messaging, and set expectations. And bringing all of these people in, again, systematically, made a huge difference that we were sending a common message from very high levels down to the very smallest communities throughout the country. And this really was a turning point in building vaccine confidence where there had been great hesitancy. Next slide, please. How do we spread the word? It happens in many ways. You know better than I do. In the upper right-hand corner, we were doing mosque announcements in India, and you can see the yellow banners in the back promoting immunization. So using prayers and sermons to make sure messaging gets delivered. In many countries, the men are making the decisions about who gets vaccinated in the household. And so making sure that the male members of the household are giving permission to women to vaccinate themselves, their children, and save their communities. We need that level of engagement. Most recently for COVID, we have in the bottom right, Dr. Philip Bonaparte has been very vocal about the need for people of faith to really embrace science. And it really, they need to put their personal interests aside in favor of the collective group. And Pastor Keith Marshall, with this very nice commentary on what does faith exempt you from? And it's not vaccination. And so having more faith leaders at the local level, in houses of worship, on the internet, all really helps us to build confidence in immunization, and it makes it less likely that people are going to use religion as a reason to opt out of vaccination. Next slide, please. I have to say we were all extremely happy when the Pope made this very passionate video urging people to receive COVID-19 vaccine. We are now trying to make sure this gets better distributed in countries around the world. I was recently on a call with our colleagues in Papua New Guinea, a country I know well because I served as a Peace Corps volunteer there. And the faith-based churches of many varieties are up and active in providing health services, but they had been left out of the planning for COVID-19 vaccine. And there are many rumors and misinformation. And so the top priority in Papua New Guinea is to get all of the faith leaders from all of the different parts of Christianity and all the groups that are there to really start with a common message of how this is important to protect us all from COVID-19. And so the Pope's leadership has been extraordinary, and we're making sure that that gets better disseminated. Next slide, please. So what more can we do for COVID vaccination and build on some of our lessons from polio eradication? One is figuring out how to better engage with some of the unnetworked groups, Pentecostals, charismatic faiths, Buddhists, Hindus, and others. We have not done a very good job on that. And we look to you and your organizations and your leadership to advise us on how best to do that. We can work together to identify actions at the country level. As noted earlier, we can be looking at advocacy and urgency in this space and how to get systematically involved. And coordination at the local level with the various groups who come at this from different positions, becomes really important. We've had a very effective coalition of both faith-based and non-faith-based organizations in the core group polio project, which runs on a secretariat model, which bundles proposals together. So people are working collaboratively rather than competitively. And we have found that this is a very successful model for engagement of civil society in general in the countries where we work, and have turned hesitancy from 40% to less than 5%. And so there are many opportunities that we see going forward, but it is urgent. The Biden administration has pledged over 1 billion doses of Pfizer vaccine between now and next September. And we are working with COVAX collaboratively to vaccinate 70% of the world by next September. We need everybody's help to do that. And we are very happy to engage and work with you wherever it makes sense. Next slide, please. And for your reference, there are some resources here based on USAID's work and convening groups over the last year to try to really capture the lessons learned. And thank you for your time. This has been really wonderful to be included as a panelist at this important event. Over.
Thank you, Ellyn, for that inspiring presentation. And I like your note about it is urgent and that it comes down to being a local advocate. And I think our faith leaders can play a significant role in that sense. Thank you again. We move on to the next panelists in the person of Tom Davis. Tom is the Global Sector Lead for Health and Nutrition in World Vision International. He has more than 35 years of domestic and international field experience in planning, implementing, and evaluating maternal child health and nutrition projects, education projects, and social and behavior change activities. Tom will share a recent barrier analysis that World Vision International conducted in the DRC, Bangladesh, and Sierra Leone. Over to you, Tom, and thanks.
Thanks, Susan. Thanks, Ellen. And good morning, afternoon, and evening to everyone. Next slide, please. So as Ellen mentioned, religious factors are the third most frequently cited reason for vaccine hesitancy globally. And faith leaders are very influential in immunization uptake through multiple mechanisms. However, to mobilize faith leaders, we really need to understand the drivers of that decision to get vaccinated with a COVID-19 vaccine by people of faith. Next slide, please. And we need to know also why some faith leaders choose to promote COVID-19 vaccines amongst the religious communities that they serve, and others do not. Next slide. So one formative research tool that we're using in World Vision for gaining that understanding was one that I developed back in 1990 called Barrier Analysis. BA is a rapid assessment, formative research tool to identify the behavioral determinants associated with a particular behavior, such as regular mask use, vaccine acceptance, or child marriage. And we do these studies in order to develop more effective behavior change activities and messages. And a real key feature of this is that you interview those doing a behavior or intending to do a behavior, the doers or the acceptors, and then you compare what they say with those who are not, the non-doers or non-acceptors. And so this allows you to look for correlations between responses and the behavior so you can identify better what is driving behavioral adoption. Barrier analysis has now been used in more than 40% of all lower and middle income countries. It was used extensively during the Ebola outbreak. It's been used for promoting polio vaccine, and World Vision is now using it to study acceptance of COVID-19 vaccines. At the bottom of the slide, you'll see the main determinants that are explored with barrier analysis. Things like perceived social norms, whether you think that people important to you approve of the behavior, but also perceived divine will, whether you believe that God wants you to do the behavior, like to get a vaccine, and beliefs about God's will. So we've conducted BA studies with a lot of different groups, such as faith leaders, adults, adolescents, community health workers, health facility workers, college students, and NGO staff. And we have conducted these studies in 22 countries so far. Next slide. So there are a lot of findings from the studies with adults, but let's hone in on the results concerning faith. In these graphs, the green bars show the percentage of vaccine acceptors, those who plan to get a COVID-19 vaccine when it's available to them. And the red bars represent the non-acceptors, those who do not plan to get a COVID-19 vaccine when it is available to them, or that aren't sure they will. So here's what we found using the BA questions on faith and faith leaders in Myanmar, Dhaka, and also Tanzania. So in Myanmar, we found that vaccine acceptors were 2.8 times more likely to say that God approves of them getting a COVID-19 vaccine. They were 1.3 times more likely to say that they had a very high level of trust in COVID-19 vaccine information provided by religious leaders. We asked whether respondents agreed or disagreed with the statement, whether I get COVID-19 or not is purely a matter of God's will or chance. The actions I take will have very little bearing on whether I get COVID-19. And in Dhaka, and these studies were led by a colleague, Kalam Abul, we found that acceptors were 1.2 times more likely to disagree a lot with that statement. That is, to believe that what they did make a difference. And acceptors were also about 1.3 times more likely to say that most of their community and faith leaders would want them to get a COVID-19 vaccine. We found similar but not identical findings in Tanzania, Bangladesh, India, and Kenya when using the BA questions on faith and faith leaders. Next slide. So this table, let's talk about one of the BA studies. Sorry, I don't remember having this slide in there, but I'll describe it. So with this, let's look at the first, sorry, if you could back up one click. I think that was the problem, that what showed up on my slide was a bit different. So let's talk about one of the BA studies. This is in the DRC, where we focus on faith leaders, and where the behavior we were promoting was COVID-19, whether they're promoting COVID-19 vaccines in the religious communities that they serve. So not if they agree with vaccines, but if their faith leaders are promoting COVID-19 vaccines. In that study, we found that about 59% of faith leaders were promoting vaccines in the religious community they served. And with BA, at least when we upload all the data using COBO, we can look at the estimated percentage of all people, like faith leaders, who believe certain things. But we generally don't find this cross-sectional data all that useful, and here's why. Look at one of the two top responses. When we ask faith leaders if they know of any religious texts or teachings that support encouraging people of faith in the religious community to get a vaccine, 77% said no, they do not know of such texts or teachings. However, and go ahead and click, when we look at faith leaders who are promoting vaccines and those who are not, there's no association there. The second small graph on the left shows that there are actually more faith leaders promoting vaccines who said no to that question than faith leaders who are not promoting vaccines. But that difference is really not statistically significant. So it's not driving the behavior. Now, it may help to provide them with those religious texts, but it's not what makes a difference on whether or not they're promoting vaccines among their faith communities right now. The same is true of the second bar. 72% of all religious leaders said that protecting the people in their faith community against COVID-19 was an advantage or would be an advantage of their promoting the vaccine, but it had no association with whether they were promoting vaccines or not. Next slide. Thank you. So what does make a difference as to whether faith leaders are promoting COVID-19 vaccines or not? Here are the main things that we found might be driving that behavior. Like in many behavior studies, social norms matter. Faith leaders who believe that about half of faith leaders are encouraging or will soon encourage people to get a COVID-19 vaccine were much more likely to be doing so now. In fact, they are about 1.8 times more likely to be promoting COVID-19 vaccines. Faith leaders who believe that most of their close family and friends would want them to encourage people of faith to get a vaccine were also much more likely to be promoting COVID-19 vaccines, almost twice as likely. Doers, those promoting the vaccines, were also twice as likely to say that they would promote vaccines if a doctor or nurse recommended that they do so than non-doers. So that's an example of a very actionable finding. We need to have medical folks reaching out to faith leaders about vaccines, discussing vaccines with them, and making that ask that they promote COVID-19 vaccines among their faith community. But social norms are not the only drivers here. Faith leaders who believe that it's very likely that someone in the religious community that they serve will get COVID-19 over the next 3 months were much more likely to be promoting vaccines, about 1.6 times more likely. And faith leaders in the DRC who promote vaccines were about twice as likely to believe that the vaccines work, to trust COVID-19 vaccines a lot, and to believe that God or Allah approves of people getting COVID-19 vaccines. So there are a lot of determinants, a lot of things driving this decision. Next slide. So don't worry about all the details on this slide. I just wanted to mention here that once you have done this sort of BA study, which often only takes a couple of days, you can then develop both messages and activities to promote the behavior, such as getting a COVID-19 vaccine or promoting COVID-19 vaccine in churches and other faith settings. For example, note the one in yellow down there for perceived social norms. Since vaccine acceptance and getting vaccinated is largely an invisible behavior, in Sierra Leone, we've recommended that people who plan to get the vaccine or that have gotten one wear either a ribbon, a pin, or a sticker to increase the perception that most people plan to get the vaccine. They can also publicize the fact that 3/4 of adults in Sierra Leone plan to get a vaccine, leveraging that descriptive social norm. These were some of the recommendations, for example, that we sent to the Ministry of Health. Next slide. Here are a few additional ways that organization can influence perceived divine will, which is one of the determinants studied in barrier analysis that we see coming up quite a bit. We have a COVID-19 vaccines module for the Channels of Hope model that World Vision's using. I know that MTI and several other organizations are also using it. Sermon guides can be very useful. Having faith leaders promoting vaccines in community meetings and using mass or social media for that purpose can also be helpful. Next slide. So World Vision is using the information from these studies, and you can too, in presentations and interactions with COVAX, UNICEF, Gavi, the Vaccine Confidence Project, this group, and also Core Group. And so we recommend that it would be great if we get more organizations collecting this sort of information, especially on faith leaders. And I've included the links here for the BA tools and a link where you can take the survey yourself just for fun. If you would like to use these barrier analysis tools to better understand a population that you're working with, including your own staff or faith leaders in your area, feel free to reach out to me. I can answer some additional questions you have and can also link you up with a technical person who can help you to do this sort of study if you're interested. Thank you.
Thank you, Tom, for that presentation. And again, you repeated the fact that religious factors are often cited as a reason for non-vaccination. We also heard that most community and faith leaders do want to get the vaccine once they get the right information. And you did give us an important question: what does make a difference? And you mentioned social norms matter. You also mentioned that medical folks need to reach out to faith leaders to promote accurate messaging, and also that faith leaders join to promote messaging on COVID vaccine in their churches, in meetings. And I think that's why we're here today, to look at the various ways in which we can make a difference. So thank you, Tom and Ellyn. And so during this brief time, participants, if you have a question or two for Ellyn or Tom, this is the time to ask it. So I am going to start off with one question that I have for Ellyn. You cited a number of reasons and ways that Usaid is looking at COVID vaccination and how to get it to the global community. So we are wondering, how does Usaid envision tracking the effectiveness of the COVID-19 messaging and the services?
Oh, Susan, that's a very, very good question. Our missions at the country level are participating in the interagency planning and monitoring of activities. Quite a number of our missions have resources for communication, for social and behavior change. So they're engaging with ministries of health, with UNICEF, with faith-based and other organizations, groups like Breakthrough Action, John Snow, Johns Hopkins, and others working in this area. They are both doing rumor monitoring and rumor listening in general. We're also looking for ways to support CAP surveys and other types of surveys. And we are hoping that we can get to a point where we can begin tracking who is missed and why. These are in many ways early days on COVID vaccine. And so we're continuing to upgrade sort of how we're understanding and our knowledge and data that's available. But we are working collaboratively with others to try to monitor what's happening at the country level. Over.
Thank you, Ellyn. That is really good to know. I have one or two more, if there are no questions coming from the participants. Tom, from the presentation that you shared, I have two more takeaways, and I'm wondering whether you can expand on it. You did say that faith leaders can either be or is a solution or can be an impediment to uptake of vaccines by community members. These are essential to our efforts to increase COVID-19 vaccination. So could you also share in various situations where we have Christians, Muslims, Buddhists, and other religions, how do we access them in, as we want to reach the last mile, the most vulnerable? Over to you, Tom.
You mean accessing them through like what mechanism we're actually going to be communicating with them?
Yes.
Yeah, well, I mean, for example, World Vision, after all the work we've done with Channels of Hope, now has, I believe it's tens of thousands of faith leaders on WhatsApp groups. I actually sit in on one of those just to kind of see the chatter and participate occasionally, but it's a very encouraging group and one where they share with each other, good vaccine information. And sometimes when something does get shared that's a bit questionable, someone will call them on it, and there's some moderation of that. I think that's a great way to reach out to them. I think also having videos, especially by faith leaders that are a bit more well-known, either getting their vaccine, talking about vaccines is great. There's also some great content. We're actually partnering with some new organizations now. Christiansandthevaccine.com has some excellent Q&A that I just used this weekend to talk to faith leaders from Latin America that actually have a church here in Geneva. But yeah, I think the real question is, we can reach them through social media where we can, but having some of that on the ground interaction where you can actually listen to them and talk with them is super important as well.
Thank you, Tom. Let's take one final question before we go to the next panelist. And this question is from Ted Lancaster, and I think it goes to you and Ellyn. The question is, how important compared to other factors is knowing the vaccine will be easily available and is free locally and reliably? Over.
I can start. I think it is very important. I think, as we said, these are early days still in the rollout of COVID vaccine internationally. We have a plan to scale up to over 1 billion doses just of Pfizer. That's not including all the other vaccines that are available over the next several months. So it has been an obstacle in the early days. But what we're also seeing, even though it is early and the supplies are more limited, we're seeing hesitation in health workers, and we are seeing expiring vaccines in places because of the lack of confidence. And so even with limited supply, we don't want to see any wastage and any expiring vaccines because people are afraid to use them. So even now with limitations, we need to be working to make sure people accept vaccination and accept what limited supply we do have. As supply becomes more available, which we're expecting it to do over the next few months, we believe the early adopters are going to line up and get the vaccine. But we're already starting to see when we get to 50 or 60% coverage, we're starting to, as I say, hit the wall on vaccine hesitancy and confidence. And absorption is slowing down, and our ability to reach those higher level targets is not there. In most of the world, only 2% of the population has been vaccinated so far. But we need to begin planning now so that once the early adopters are vaccinated, that we don't hit a wall in these countries at 20 or 30% coverage. So we know how long it takes to address vaccine hesitancy and build confidence. So we need to work on this now as a timing issue. That's why the urgency. So that once we do get all the early adopters vaccinated, we can continue to accelerate absorption. And this is where we really need to be working together over the next few months. There's a lot of synergy between the supply and the demand side, but we need to begin that work now. Over.
Thank you, Ellyn, for that response. And I think we can move on to the next panelist. Please continue to put your questions in the Q&A box as you hear from the next speakers or as you reflect from Ellyn and Tom's presentation. We'll have time for questions with all the speakers at the end. Now we'll hear from Sara Melillo about the research she conducted for CCIH, supported by the Usaid-funded Momentum Country and Global Leadership Project. By way of introduction, Sara is an independent global health technical consultant with a strong interest in faith leader engagement and has worked for and at with a lot of faith-based organizations and donor agencies. Sara was engaged by CCIH under the Momentum Country and Global Leadership Program to update a literature review, interview global stakeholders, and do deep dives of faith leader engagement strategies in 4 countries. There's a publication that is upcoming, and I'm sure Sara will tell us more about that. Over to you, Sarah.
Thanks very much, Susan. Really appreciate it. And thanks everyone for joining us today. I see some actual key informants who participated in this research, so I'm really looking forward to sharing some highlights. Today, I'm going to very quickly present the findings from a study you can see on your screen, where we looked at the impact and how we could find promising practices for promoting and scaling up COVID-19 immunization. And as Susan mentioned, this was under momentum, country, and global leadership. We only have a short time today, so I really encourage you to look at the 15 promising practices that we will circulate after this webinar, so you can really do a deeper dive. But just in general, our goal was to build on an earlier evidence summary on the effects of faith actors on the uptake of immunizations. And we've already heard a lot of rich information from Tom and others. Today, I'm going to share a bit on a deep dive in 4 countries: Ghana, Indonesia, Sierra Leone, and Uganda. And I'm really excited that Bishop Sheldon is following me, who's really going to bring a lot of this to life for us. Just by way of methodology, we did a quick desk review, and I conducted 17 key informant interviews with faith-based organizations, Ministry of Health representatives, and CSOs in these 4 focal countries, so we could identify some of the key themes. And these countries were selected based upon 4 criteria: a documented history of engagement in immunization and faith leaders, the robust presence and influence of religious leaders in household decision-making, which I think you all know, their ability to contribute to new learning, and of course, synergy with other USAID programming and investments, some of which we heard from Ellyn. Next slide. So what were our headlines here? What did we learn? And I see, sorry for this tiny title here, but at least you can see the kind of 4 key points. First, we found both good and bad news, if we're summarizing and being glib. First and foremost, I think the findings show that this is a call to action to engage and invest in local faith actors in highly religious countries to serve as central partners to ministries of health and global technical bodies in COVID-19 vaccination. The promising practices that I'll highlight quickly today, these extend beyond the traditional sermon guides. I think we hear a lot about sort of sermon guides and creating them for faith leaders. That is one promising practice, but there is really a rich wealth of them. And these are things that ministries of health, donors, local faith actors themselves can look at and see what role they could play in advancing this. And these should be scaled up. The second headline is, of course, that public COVID-19 vaccination by top religious leaders seems to have a positive effect on increasing vaccine uptake in all 4 of these countries, and we would extrapolate highly religious settings. COVID-19 vaccine social media disinformation is a huge new game changer. I think you all are on this call and are well versed in this, but it's just important to note that that's going to require new promising practices by faith actors to address this, as well as society as a whole. And finally, we want to see more engagement of local faith actors. I think everyone on this call agrees in that, but this research really supports that, the potential impact they can play. Next slide. So let's take a pit stop here before we go into what some of the promising practices are. Tom shared a lot of rich data for DRC and other places from the Barrier Analysis. What did we find from this study? There were kind of 4 key points. I think before we dive into religiously linked vaccine hesitancy, though, it's important to note that my findings align with the Nature Medicine study from July that shows high acceptability in low and middle income countries for the COVID-19 vaccine as compared to the US and Russia. So really want to underscore this, as Ellyn was talking about, the coverage is just abysmally low, the supply, everybody's working to increase this. So I do want to, caution that focusing on hesitancy it's an important planning tool. Like Ellyn's saying, we do want to plan to scale up, but let's not, kind of pigeonhole that there's a lot of hesitancy if it doesn't exist. What we found in these 4 countries were few major religious objections to COVID-19 vaccination. There were pockets who had publicly objected. For example, some of the indigenous faiths in Ghana, within Uganda, the Abajiri, people of the 666 gospel. So there are pockets of different smaller minority religions publicly objecting, but in general, the major religious faiths have been very supportive. You can see that note up there from the perceived divine will from Sierra Leone, thanks to colleagues in World Vision. This is just one example, and I won't wax poetic of, what are some of these religious factors. The earlier study that USAID conducted of the global literature review found that there were a number of other kind of non-religious factors that often serve as a proxy for religious-based vaccine hesitancy. So that's something to keep in mind. There are non-religiously linked vaccine hesitancy factors as well. Those are things like perceived efficacy of the vaccine. That's very important in Indonesia. We found whether someone wants to take the vaccine. In Sierra Leone, we found the perceived risk of contracting the disease was, kind of an important factor around it. And vaccine nationalism seems to be an important theme in Uganda and other places. Next slide. So I'm not going to read out these key informant interview quotes. This is from Ghana. Rather, I'm going to let you read them yourselves. But some important themes here you can see are vaccine hesitancy being, vaccine nationalism being an important point of consideration, social media being a huge driver. One of the key informants from Indonesia noted, very highly educated, very pro-vaccine, noted, when you receive the information on your phone 10 times a day on WhatsApp about the vaccine saying it's bad, you start to believe it. So it's an important, the social media piece is really kind of important. Next slide. There are a lot of wonderful, promising practices. Religious leaders have been at the forefront. I think Ellyn was showing earlier the Pope's kind of proclamation at a global level being a facilitator. I know that was really helpful in Uganda. One of the key informants said, here in Ghana, here's just a nice example of the chairman of the Church of Pentecost kind of playing a leading role in COVID-19 vaccination and getting publicly vaccinated. 1 out of 7 people in Ghana is Pentecostal. So that's, kind of a very influential factor. An important point in Ghana and other countries was the amount of philanthropic cash and in-kind resources that local faith actors are putting forward themselves, right? It's not just a donor-funded initiative. They're marshaling their own resources to take care of their own communities, and something that should be augmented, amplified, and leveraged for this effort. It was a big theme we found in all the countries. Next slide. So as I mentioned, the full report has 15 promising practices on how we can engage local faith actors to increase acceptability and uptake and coverage. On the slide, you'll see basically there were 4 buckets that we found that these promising practices fell into. I'm not going to go through all of the 15 practices, but they each kind of nest underneath these. The first being working with religious actors and working through any concerns they have around vaccination and identifying entry points in different scriptures and other faith-linked documents. One important point, I think, was from many of the key informants is that in multiple countries is we need to create safe spaces for faith actors in private confidential settings to air their own questions, their own concerns about the vaccine before kind of moving forward and asking them to do social mobilization and other pieces. The second bucket, which I think had 3 or 4 kind of promising practices, is strengthening collaboration among faith actors and civil society on vaccine promotion and delivery. This includes things like working with interfaith councils, holding interfaith discussion forums, and things, for example, like pulpit swaps that were done during the Ebola pandemic in West Africa and Sierra Leone, where Muslim and Christian faith leaders kind of unified and shared community messages across each other's kind of pulpits and things. I think under bucket 4, it's important to note that engaging respected scientific intermediaries like faith-based health associations, of which I see some of whom are on the call, or other trusted scientific bodies who are trusted by faith leaders, working with them to kind of provide easy to digest scientific information, especially in relation to a new vaccine, of which there are many questions. Next slide. One of the promising practices found in Uganda was family health days. I don't have a lot of time to talk about this, so I recommend you look at the report, but it was a great combination of using actual service delivery for immunization after services each week and providing routine immunization to children. And this is something that's really could be used in the future to reach adults who are going to church regularly for COVID-19 vaccines as well as boosters. Next slide. So, you know, with any group, there are always, you know, kind of challenges we need to be aware of. What are some of the operational challenges of working with faith actors for immunization? You can see here on the list, I don't think any of them are too dramatic or too new, but they're just things that we have to keep in mind when we're engaging faith actors. You can see COVID-19 worship gathering bans can be a challenge. Interfaith bodies may include vaccine hesitant local faith actors. So these are kind of things to keep in mind when looking at the promising practices. Next slide. So I just want to note, and you'll receive this slide deck, there was an earlier landscape analysis that I think you'll all be quite interested in around what the evidence is on engaging faith leaders in routine immunization. It touches on COVID-19. You can see the link there. And there's some other really great faith-based immunization resources if you're planning on working with faith actors. Thank you very much.
Thank you, Sarah. And I think you made an important point about there are important non-religious factors that influence all of our thinking and our behaviors. And I do think that it goes back to the point where I think Tom made that health staff need to inform local faith leaders on accurate messaging of the importance and the usefulness of the COVID vaccine and what the international community is trying to achieve. So now we're getting to another exciting piece. We get to hear from a religious leader from Uganda in the person of Reverend Sheldon Nisega, Bishop of the Ankola Church of Uganda. Bishop will share his personal story from hesitancy about COVID vaccine to acceptance and how he promoted information on COVID-19. This will be in the form of a short video featuring our own Doug Fountain from CCIH and Reverend Sheldon. So please let us relax and enjoy the video.
Bishop Sheldon Nisega. He's the bishop of the Ankola Diocese of the Church of Uganda and is also the chancellor of Bishop Stewart University in Mbarara. We're grateful for the opportunity to speak with you today, Bishop. Thank you for taking the time.
Thank you, Doug. It is a pleasure to be interviewed by you. Good.
We've known each other for a good number of years, and I've known your spirit and your heart for the people in Uganda and appreciate your leadership. We learned recently that the House of Bishops selected you to actually be on point to go and find out information about the COVID vaccine. Tell us a little bit about why the House of Bishops wanted you to do that, and what did you learn from that? What were some of the big things that came from that experience?
Thank you, Doug. I think what exactly happened is that we have some link with Bristol Diocese. As how is it the situation of COVID-19? And then we told them that now we are in the phase whereby they are saying we need to use vaccines, but very many people are hesitant. And I told them that I was one of them who was very hesitant. And but I told them that I was concerned that I had my mother who is 90 years old and asked, could she be able to take the vaccine at 90? And in that discussion, Chris Dobson, who is the global officer, ecumenical officer for Bristol, said, oh, by the way, we in our congregation, we have a Christian scientist who works at Oxford University. Jenna, she was willing, and she answered almost all the questions that I had. And from then on, I caught the fire.
Oh,
of the
wow.
vaccination, and I got my mother vaccinated. I also got vaccinated. I mobilized around especially the aged 70 years, 80, 90, and we have a good number Christians who have been loving their God, living godly lives, careful about their health. I was so worried that they could be decimated by this new virus. And so as I speak, I thank God that this was done. And as I speak, I really thank God because in my diocese, we lost one elderly priest before we had gotten even the vaccinations. But after that, we have had 3 priests who had COVID, but they have recovered. And almost all my priests now are vaccinated. And we really thank God. So we see that really the assurance we got. Later, we even had the House of Bishops to engage with the 2 of the team who were involved in vaccine development, Dr. Marion Watson from Oxford University and Dr. Mustafa Bitai, a Gambian. You know, one of the questions was, maybe there's any secret agenda to decimate Africans. And here was on the team, an African Gambian. So, and many other questions. So we really thank God. We've come to believe that it works. We've encouraged people to have the vaccines, and we believe they make a difference.
What do you think is driving that fear? When you say people are concerned that the vaccine could decimate Africa, people aren't saying the COVID will decimate Africa. They're saying the vaccine could decimate Africa. So what's behind that, do you think?
I think mainly the social media is what rules the world now. There is a lot of negative information on social media in the direction of saying vaccines are dangerous. But of course, the justification some of them do have is that over time in history, there have been some examples of medicine being used maybe to cause some havoc. True, science sometimes has been used for wrong reasons, but we need to appreciate that science, for the most part, is the reason why many of our people are living.
Have you had any kind of pushback against your thinking or your leadership, or anybody saying we don't want to hear the church speak to this? Or is the church actually able to help change people's hearts and minds at this time?
In Uganda, we are very lucky. Actually, the medical superintendent for Barrier Regional Referral Hospital was appreciating me and saying, thank you, Bishop, for speaking out. You've helped us. That's why we've been able to do a lot of vaccinations in our region. Ankole region is one of those which is doing well, because as a religious leader, I've spoken out, and a few others. Some of the religious leaders are also not talking. They know best why they are not talking, but I'm someone who is always guided by the word of God, because we are on the watchtower, because the word of God, I think is it in Ezekiel, which says we are a watchman. If blood of the people spills and you have not warned them, that blood of those people will be on your hands. But if these people, you talk to them and they don't heed to the warning, then you have no case. So for me, I take that seriously. As a leader, I have a level that I've gone to, even of education, even of exposure, even my faith as a leader, where I feel I have an obligation to guide my Christian. So I thank God that the medical world has appreciated. Actually, the problem is from the Christians themselves. Some Christians, especially in Kampala, there are some pastors, there are some priests who are also discouraging people from taking vaccines. They are talking of 666, the mark of the beast, and all kind of queer things. But sadly, actually, a good number are also, we are getting cases of some dying. And I think that way probably some will wake up and realize. So the greatest negativity is coming from some Christians, not from medical people, not from politicians, but some Christians. And even these Christians, I want to believe actually they are getting the messages from even, Lord forbid, probably even as far as the US, because the Christians in the US are very negative to some of them, I must say, the conservative, they are very negative. And to vaccines, which I read, and many of them relate. So I want to imagine this is where the problem actually might be coming from more than any other place. But as on my part, we are the Archbishop himself was vaccinated publicly, actually Church of Uganda. It is us who have come out. Other churches also, you don't see them easily coming out to be in the open, really. But as of now, where we are, there is hunger for the vaccines in Uganda, very big hunger. People have come to appreciate them, actually, I must say.
Thank you very much, Bishop. I really appreciate you taking some time to meet with us today.
Welcome.
Thank you very much, Bishop and Doug, for that short interview. And I think you all brought up a very good point about faith and science, that it's knowing that science does help people change their minds and move from hesitancy to voluntary acceptance. And you also indicated that social media plays an important role in our mindset. And so with that, just want to thank all the presenters of this morning. And we have a couple of questions before we end our session today. So the one of the questions that I have here is from Stephanie. And it is, the question is there already a great literature report available on Sarah's research on faith leader engagement? So Sara Melillo, I think this is your question.
Thank you, and thanks so much for your interest. So there's a couple resources. Number one, and I think we can put the link in the chat, we do have a report available on the USAID Momentum website that is the Global Literature Review on Faith Engagement and Immunization. So if someone could pop that in the chat, or I'll do that after I answer, that is available. Now, the promising practices in these specific 4 countries, that's undergoing review and will probably be online in about the next week. So we will definitely, all of the webinar participants will have a link shared with them, so you'll have access to that.
Thank you, Sarah. And our next question is on social media, and it is, we've seen the role social media has played in the spreading of disinformation about COVID-19 vaccine. Are there any thoughts or examples of how social media is being used by the faith community to combat disinformation with truth? And this is from Joe DiCarlo.
I'm happy. While my colleagues, I'm sure they have examples to share. I'll share at least from Indonesia. Muhammadiyah, which is it is the largest faith-based organization of Muslim adherents in Indonesia. They have a WhatsApp group of, I believe, something like 18,000 folks, a decentralized structure, and they actually have a great social media campaign going on encouraging vaccination. I'm trying to see if I can pull up the actual visual of their campaign. If I can later on, but I will do so. So that's a wonderful example, but I think my colleagues, Bishop Sheldon or others, will probably share examples as well.
Yes, thank you, Sarah. I think I can add that one of the things I've been engaged in, I write in Ugandan newspapers, the major newspapers, New Vision and Monitor newspaper. So I've written articles which can be available to you. I think Kathy has them and Doug Fountain has them. You'll see newspapers which have been written, and some extracts have been put also on social media, and they really move. And very many people have been responding and appreciating, and there are those also who have been criticizing. So yes, it can be done. Once we get information, we can post it there, and it moves through all contacts.
I would just add, this wasn't with faith leaders per se, but there's a group called AI Fluence out of Kenya that basically has a model where they identify people using artificial intelligence on Twitter and Facebook that seem to be, fit certain characteristics. And one of them could be that they discuss faith, and find out who are those most influential people. And then they basically contract with them to give them content that they can push out through their social media channel more often. Yeah. And I think that's something that would be a great service if we could identify some of those faith leaders who are the most influential, and then really even combining with things like Barrier Analysis, so that they're not only speaking things they might consider, but remembering, oh, wow, we need to convince people that COVID-19 is serious as well. It's not only the social norms aspect, and I'm looking forward to seeing something like that happen through our work with World Vision in the coming year.
Yeah, Davis, I could add that personally in my phone, I have 1,000 contacts. And normally I have even Zoom services, which we began during the COVID pandemic. And so I send messages to 1,000 people. And I have status where I post different articles about COVID, the dangers. And so about 200 visits the status report. So it works if we use that model. Very good one. Yeah.
Anything else from the panelists? If not, then I can go to the next question. The next question is from Peter Yabua, and he says, he asked, would intentional comprehensive engagement or customized role for religious leaders in all COVID-19 response actions, for example, risk communication, case management, contact tracing, surveillance, complement, here, I'm trying to get the question off of the chat box. Will these complement vaccine uptake in what we're doing? That's number one. And then would harnessing the trust, networks, pulpit, captive audience, and social access, etc., also improve vaccine uptake? And could we do this 24/7 as we on, ensuring that people hear and people move towards voluntary acceptance and access? Over to the panelists.
What I can start and say, yes, absolutely. We need to be doing this 24/7, and certainly activities that support communities to deal with COVID itself, not just vaccination, are very important. One of the things we're learning is that part of the reason for vaccine hesitancy is that, or vaccine apathy, as we're hearing, is people don't believe COVID's an issue. They don't think it is affecting their communities. They don't believe that it is important compared to other priorities. Part of that is a lack of testing. Part of it is a lack of contact tracing. And the more people understand how COVID-19 affects their communities, may affect their own long-term health, that may not be apparent right now, I think is a foundational issue for finally accepting vaccine. They have to believe a perceived risk, that it is a problem. Over.
Yeah, I would add definitely risk communication, obviously, but case management, maybe not fully, but at least in terms of like learning how to use some simple screening tools, knowing symptoms, being able to tell people when you need to get to the hospital and when you're okay, just staying at home. We've developed an app, for example, that community health workers who are sometimes partially literate they could still use. I could definitely see faith leaders using some of those tools to be able to keep an eye on things and to feel like they're more engaged with this.
Thank you, Ellyn and Tom. And there's another question from Peter. Has there been any intentional COVID literacy and immunization program for religious leaders to deal with the seeming ignorance or unintended vaccine hesitancy?
That's a great question, Peter. And I also want to mention that I know Christian Health Association of Ghana has really been at the forefront of engaging with faith leaders on a number of efforts. So I encourage people to reach out to Peter offline to learn more about what they're doing with their FCDO funded project. In terms of actual global kind of curricula or kind of approaches, I personally did not encounter or see or hear that in the 4 kind of country deep dives we did, but even earlier in the sort of global literature review, it didn't come up as well. So I do think that that might be something. There's certainly a number of resources. I don't want to minimize that. And if you kind of comb through these reports, you'll see them. But I do think that is a sort of a gap, and one that I think CCIH is looking at under momentum, trying to work with folks to sort of fulfill, to create some social and behavioral change messaging and toolkits and things that could be adapted. Because I think, as Tom and Ellyn and Bishop Sheldon know, right, so much is local context. So if we can address some of the key kind of issues, concerns, and approaches, it could then be contextualized based on the local barriers or beliefs or, you know, kind of things like that. So I'll pause there.
Now, let me add that I think Dan might have mentioned this in the chat, but World Vision Canada actually is leading some work that will be happening about between now and June, where we'll be working in 2 or 3 countries in Africa with other faith-based organizations. And part of that will be developing like a website, having a lot more content and vaccine literacy materials for faith leaders. And we'll definitely be, coordinating with CCIH on this to try to get those resources out to more people, because we need more content.
Thank you. And as we come to the close of our session, I wonder if any of the panelists have, a one sentence takeaway for each one of us who participated on this during this session. Tom?
Sure. Don't assume that things are the same in every context. Use formative research to find out what you need to be doing in order to engage with faith leaders effectively.
Sarah?
Don't assume a scientific answer for every challenge. People's concerns come from a lot of places, so not every hammer is a nail. Listen to people where they are.
Bishop Sheldon?
Yes, we are continuing to organize seminars to sensitize religious leaders about the importance of vaccine uptake, and also to point out, as Davis says, examples, live examples of deaths and live examples of those who have been healed. And when we do that, we shall get very far.
And last but not least, Ellyn.
I would emphasize the need to listen and make sure we understand where people are coming from, what their priorities are, understanding their concerns. I often feel that hesitancy and confidence are due to a lack of our ability to communicate as health professionals. And we can't blame communities for having what could be very real, concerns and suspicions. And so we have to do a better job of explaining ourselves and convincing people why this is important to them and their families. And it's going to take all of us. So I want to thank you all.
And on that note, thank you to all our panelists, and I'll hand it back to Doug. Thank you.
Wow. Thank you so much, Susan. Thank you to each of our presenters and panelists. A really remarkable job to take us through such terrific content and so much for us to consider and digest. Thank you to all of the participants who've joined us for this session today. We hope you've enjoyed the session. CCIH and World Vision would like to hear your thoughts on the webinar and put together a very brief questionnaire. We put together a very brief questionnaire with just one question on it. So please look in the chat box. The link is being put in there right now. Follow that link and tell us one thing you have to say about the webinar today. So is that in there yet? I've just lost my chat box. That's okay. All right, folks. Thank you all for taking time. Let me close this in prayer. Gracious God, thank you for giving us, your children, the opportunity to learn from each other, to listen, and then apply these important lessons for the sake of the health of all, especially those who may yet come in harm's way from COVID. In your holy name we pray. Amen. Thank you all. Really appreciate it.
Thanks, everyone.
Thank you.
Thank you.